UOA for the very kind invitation to speak. Um, I have no disclosures for this talk. So my outline of the talk would be talking about conventional imaging strategies, the different types of radio tracers we use in PET scans, the utility of PET scans in prostate cancer per se, and the guidelines and the role of PET scans after all the data, and what are the emerging frontiers. So all of us use conventional imaging, and we know that there are limitations to these imagings. For example, in T-staging, multiparametric MRI is currently the imaging of choice. We are talking about extraprostatic extension or seminal vesicle invasion. In terms of N-staging, there's a limitation in terms of this staging, this imaging for CT and MR, because we use the size criteria, usually a 10 mm threshold, and using the lymph node morphological structure to detect nodal involvement. The problem is that the overall detection rate is quite low. It's about less than 40%. And in terms of metastatic M staging, bone scan has really very limited sensitivity and specificity. NCCN recommends that we do bone scan when the patient's PSA is more than 20 or T2 disease plus PSA more than 10. So in terms of biochemical recurrence, for restaging, conventionally, we use MRI or contrast CT for nodal disease, and we know this is limited. In terms of bone scans, there's a low detection rate in biochemical recurrence, particularly when the PSA level is low. And EAU currently recommends this kind of investigations with conventional imaging only when the PSA is more than 10, when the patient has biochemical recurrence after radical treatment. Now, in terms of assessment of response, in MCRPC, we know that PSA measurement is not as reliable anymore when the disease goes into castrate-resistant state. Using CT, bone scan, and MR, these are really late indicators of treatment efficacy. You need, basically, these changes will only be seen after 3 months from therapy. Then you will start seeing changes on the MR or CT. In terms of bone scan also has some limitations with regards to the flare phenomenon, and there is also a non-specificity of the osteoblastic activity. Now that, of course, we know there are limitations to conventional imaging, what is the role of PET scan in prostate cancer? Now, there are several PET tracers available in the market. We have the conventional FDG PET that is being used for many solid tumors, and then we have the choline PET that is still currently in use in many centers, but is slowly being replaced by PSMA PET. And then there's the new kid on the block, the fluciclovin PET, and then we have the sodium fluoride PET, mainly for bone imaging. Now, what FDG PET is the conventional imaging that's been well utilized in other disciplines. We know FDG is a glucose analog taken by cells because of it's by way of glucose transporter proteins. Now, we know that most prostate cancers use a non-glucose metabolic pathway. And therefore, what's the role in prostate cancer? Very limited, because overall the sensitivity and specificity is quite low. And currently in NCCN guidelines last year, it was declared there was no role of FDG PET in prostate cancer. Now, what about sodium fluoride PET? Sodium fluoride is an analog of the hydroxyl group of the hydroxyapatite bone crystals, and therefore it's a bone seeker. Still, it's non-specific in uptake because the uptake really reflects osteoblastic activity, and it's not specific to cancer, but really, and it also does not assess the soft tissue. So these are its limitations. Now, there is a meta-analysis of sodium fluoride PET used in prostate cancer. It was suggested, looking at the curves, that it seems to be superior to bone scan, conventional bone scan for bone metastasis detection. Its pooled sensitivity and specificity was in the high 90s, 96 and 98%, compared to bone scan, which was the sensitivity was 57% only. And of course, the only problem is that it's more costly, so it's determined to be less cost effective. Now, oh, what is happening? Okay. Okay. I guess what to press anyway. So anyway, choline PET. Now, choline PET is choline is an essential component of cell membrane phospholipid. It's metabolized and internalized into the cells by choline kinase, an enzyme that is expressed in certain tumors such as prostate cancer. Now, we have two types of isotope conventionally, the 11C and the 18F choline. What 11C is really has a short half-life, 20 minutes. Therefore, it needs to be done an on-site cyclotron and less urinary excretion. F isotope has a long half-life, therefore it can be transported to other centers. So C isotope has a limitation that it has to be on-site. Now, in terms of initial staging, there's limited value in localizing primary tumor. So we know that for primary tumor itself, it's not very good. Now, how does it compare with other imaging such as bones for bone mets? Now, this is a meta-analysis again on detection of bone mets at initial primary staging. So, choline PET was used to compare with MRI, bone scan, and SPECT CT. So basically, if you look, I don't want to overload with all the information, but if you look at the sensitivity and specificity, if you look at PET, generally the specificity is high and the sensitivity is good. So this is by per patient and per lesion. So in the pooled specificity, this was 0.93 for choline PET and 0.85 for bone and SPECT CT and 0.7 for bone scan alone. Now, for per patient basis, MRI for detection of bone met seems to be better than the choline PET. But per lesion basis, choline PET seems to have the highest odds ratio compared to bone SPECT and bone scan for detecting bone metastases. In other words, actually choline PET or MRI seems to be pretty good for bone metastasis detection compared to bone scan. Now, in terms of biochemical recurrence for choline, this is again another meta-analysis. This was really to look at the diagnostic accuracies of choline PET for lymph nodes and prostatic fossa recurrence. If you look at the sensitivity and specificity, it was quite high for lymph nodes, but not as good for prostatic fossa relapse. If you look at other studies for using MR imaging, still it suggests that for prostate fossa recurrence after radical prostatectomy, MR imaging seems to be still superior at that overall detection rate of 83% compared to choline PET. Now, let's move on to what's newer and most exciting is PSMA PET. PSMA is actually a type 2 transmembrane glycoprotein. It's overexpressed about 100 to 1,000 times in most of the prostate cancer compared to other sites. Its expression tends to be correlated with disease aggressiveness. The more aggressive the disease, the more likely you're going to have PSMA expression. Now, most widely used is gallium-68. It's still not FDA approved yet. This is one instance when America lags behind for this data. Non-prostate PSMA can be expressed in other tumors as well, such as lung cancers, glioblastoma multiforme, HCC, and certain sarcoidosis and Paget's disease. So this is one of the pitfalls you must also realize. Now, for PSMA, its utility in lymph node staging, this is a study of 130 patients of intermediate to high-risk cancers staged with PSMA PET, MR, or CT before prostatectomy and lymph node dissection. If you look at the red curve, which represents the PSMA PET, this is compared to conventional imaging of CT or MR on the blue curves. Based on the patient, if you look at the ROC curves, and per patient analysis, the sensitivity, specificity, and accuracy of PET, PSMA PET was much better compared to CT or MR. So if you look at the specificity of 98%, sensitivity of 65%, almost 66%. So PSMA PET was considered to be superior to routine imaging for lymph node staging. What about for bone staging? This, again, 126 patients that undergo bone scan and PSMA PET CT within 3 months of each other. This basically is for primary staging again. We won't go through this very heavy slide, but if you look at the per patient and region based on this is a PET and this is bone scan. You generally see that there is a p-value which reflects a better sensitivity and specificity, and basically PSMA PET outperforms bone scan for detection of affected bone regions as determined by overall bone involvement on prostate cancer patients. In terms of biochemical relapse after radical prostatectomy or radiation therapy, this is a small prospective study of 38 patients where they did choline PET, PSMA PET, and contrast CT within 30 days of each other. So these patients really have received a lot of imaging within 1 month, right? If you look at the performance of choline PET versus PSMA PET, at low PSA levels of less than 0.5 or 0.5 to 2, really PSMA PET has a better performance in higher detection rate, 50 to 71% versus 12.5 and 36%. You can see in the black curves, these are PSMA, and this is choline. So basically, they detect more lesions. And also, in terms of change of management, overall impact of managing change in management was higher in the PSMA group. So patients with biochemical recurrence and a low PSA level, PSMA PET-CT demonstrated significantly higher detection rate than this choline PET and higher overall impact on patient management, right? So again, this is a meta-analysis, very recent one, looking at 1,300 patients for using PET for primary staging and biochemical recurrence after radical treatment. And this is compared to CT and MR. So if you look at per patient and per lesion, the sensitivity and specificity was at least in the high 80s to 90%. And compared to CT and MR, the sensitivity and specificity was rather low. And what's important is that if you look at the PSMA positivity in correlation to doubling time, if the doubling time was fast, the positive scan rate was very high, 92%. If the doubling time was more than 6 months, it was 64%. So in this same meta-analysis, what also was useful information was that looking at the PSA level and positive scan detection rate. So what's good about utility of PSMA PET was that at very low PSA levels, you already have a pretty high scan positive rate. So even from 0.2 to 1, you get a 58% already. So in my practice, my cutoff is usually 1. If you have more than 1, I would to do a PET, I would do a PSMA PET, and it's likely to be positive. So at PSA more than 2, you have a very high positive rate on the PSMA PET. Also, in this systematic review and meta-analysis, this was a pooled patient looking at basically the intention versus intended, implemented versus intended when they talk about the impact of PSMA PET on the management of patients with prostate cancer. So basically looking at this, if you look at this hazard ratios is about 0.5, 0.5, 0.5. So what it meant was that PSMA actually led to a change in management is about 54% of cases, and basically altered the decision of the referring physician or multidisciplinary committee in about half the patient, basically change of management, right? So what about fluciclovin? Just a little bit of introduction in fluciclovin. This tracer is suggested to be superior to choline in patients with biochemical relapse after local therapy, and it's a favorable biodistribution with relatively less urine excretion so that they don't block, the tracer doesn't block and cause imaging blockage when you try and read the CT. Now, interestingly, fluciclovin has been FDA approved for patients with biochemical relapse, but it's based on very, very limited data, which is still emerging. So one of the initial data was 50 patients with who was radically treated for prostate cancer with primary intent and rising PSA levels. They both went for choline and fluciclovin PET within 1 week. And if you look at the per patient analysis in 50 patients, what's interesting is those who had choline negative, there were 6 patients who were fluciclovin positive. But those who had fluciclovin negative, none of them were choline positive. So on this basis, fluciclovin was provided, showed that it was significantly better performance in terms of lesion detection rate compared to choline PET. Now, this is a summary with NCCN guidelines showing that basically FDA status, the only one not cleared is PSMA and the new C11 acetate. Basically, the rest have been cleared. But if you look at the percentage, sensitivity and specificity, PSMA PET seems to have the best performance characteristic compared to all, although head-to-head comparisons are lacking. Now, if you look at EAU guidelines, this is in terms of recurrence after prostatectomy. If your PSA level is more than 1, the recommendation is to consider doing a PSMA PET or a choline PET, or if available, or a choline PET imaging otherwise. So this is after radical prostatectomy. PSA recurrence after radiation therapy, the recommendation is to perform a multiparametric MRI with biopsies with a level of evidence 3, but level of evidence 2B, it was to perform a PSMA PET or choline PET to rule out positive nodes or distant metastases. There is no recommendation for PET scans for initial staging yet or CRPC. So it's only for recurrent biochemical recurrence. So my own analysis is, what's the optimal role of PET scans in prostate cancer? For choline, it's really for biochemical recurrence after radical therapy in patients with high PSA level and high PSA velocities. The blue ones are really possible use, but not within guidelines. So this is NCCN guidelines. Possible use is for staging of high risk, very high risk prostate cancer. Possible use for equivocal findings on conventional imaging that you try to figure out what's going on because it's discrepant from a clinical picture, such as very high PSA. PSMA PET, according to guidelines, is for biochemical relapse after radical therapy in patients with low PSA levels. The possible use is the same as choline. And there's also emerging use where, in purple, where it's labeling of PSMA ligands for therapy, which we'll discuss in a short while. And then, of course, whether you can use this for primary prostate evaluation in combination with MR. So sodium fluoride PET is very limited, not routinely recommended in EAU, but you can use it to be an arbiter to decide for equivocal bone findings on conventional imaging, and fluciclovin is for biochemical relapse after radical therapy according to NCCN. So what are issues with PET scans use? The issue is with stage migration towards advanced disease is what we call lead time bias. We all understand that. PET scans may change treatment but may not change oncology outcome. That's called the Will Rogers phenomenon, where most trials use conventional imaging. Use them, we don't know whether they really will benefit from these trials or not. And of course, the cost and cost effectiveness are problems, and of course, ability and access are also key issues. I showed quickly very short cases. A 65-year-old man with prostate cancer, high-grade PSA 20, multiparametric MR shows a possible early EPE and no enlargement. Bone scan was negative, and after radical prostatectomy, it was PT3B N0, separate margins were negative. Post-op PSA was still highish at 0.15. This patient rejected subsequent treatment and had a PSA rising after 10 months to 5.3. We did conventional scans, it was negative, and a PSMA PET showed there was a retroperitoneal node positive here. And so basically, there was common islet and retroperitoneal nodes positive. We started ADT, we also started an abiraterone based on STAMPEDE data, but these nodes were based on PSMA and not conventional imaging. So I leave it to you to decide if it still applies. Case 2 is a 68-year-old man, retention of urine, constipation, prostate cancer, high grade, PSA was 150. Now the MRI shows it's a locally advanced prostate into the bladder, the pelvic sidewall, the rectum, and lymph nodes. The conventional imaging showed that there was no metastases in bone scan or distant in the CT scan. But the PSMA, we did a PSMA PET MR to see whether there's actually metastases because the PSA was 150. So what it did show was no metastases, but very severe local extension into the, and so initially it was planned for radical cystoprostatectomy, but we couldn't resect because it infiltrated into the right the sciatic nerve foramen. So this patient had poor response to ADT. We gave chemotherapy and was treated with radiation therapy. So the number of emerging frontiers, which I'll go very briefly, I know the time is limited. So there's some role in primary prostate evaluation in combination with PET MR, where there's combination of PET MR seems to be better than MR or PET alone. There's ongoing trials. I myself have one study on this. There's some role, there are 2 trials looking at PET's role in active surveillance, and also the use of nomograms included, which includes PET scan in nomograms. And then lastly, there's theranostic, where in the German center, using 1 to 4 cycles of lutetium PSMA, about almost half patients had PSA decline more than 50%, and these are heavily pre-treated with many other treatments before. The good thing is that the toxicity is low. The grade 3 neutropenia is about 3% compared to docetaxel 12%. And also, in another study, in a phase 2 study for lutetium PSMA, basically you can see the blue, where many of them achieve more than 50% PSA reduction, and up to 30, almost 30% had complete response, and these are heavily pretreated. And of course, importantly, the patients all improve in terms of pain, and grade 3 and 4 neutropenia and hematological side effects are not very high. So these are some dramatic response you see from heavy prostate cancer, and after lutetium, they